All right, well, we're very happy today to have Dr. Jeff Bradley from Washington University. He is a professor of radiation oncology. He's also the medical director of the Proton Center at Washington University. Additionally, he is the leader of the lung cancer core group for NRG Oncology. He's a friend of many of the lung cancer specialists in the room, and we're excited to have him here giving us a talk on proton therapy for lung cancer.
Good morning, and thanks for having me. I hear Emory's putting in a proton center, is that right? Okay, that's what I heard. So I decided to give you a proton center talk. This one, I'm a lung cancer specialist, so this one's about lung cancer. So we'll tell you a little bit about our center, and then we'll get into the pros and cons of radiation therapy or proton beam radiation therapy for lung cancer, and I hope it's balanced based on data. So for those of you who aren't familiar with proton beam radiation in a lung cancer, this is why you might want to do it, because on your left is intensity modulated radiation therapy, which is what pretty much everybody uses today. The red dose is your target dose, and the green and blue doses are excess dose because you're using x-rays and it deposits dose wherever the x-rays go. On the proton side, on the right, you get less low dose spillage in the ipsilateral lung, contralateral lung, and heart. And the hope is with proton beam, you reduce the dose to those structures. You can reduce side effects for sure, and whether you improve outcomes in terms of tumor control, et cetera, is undetermined. But I'm fairly convinced in this situation you spare side effects for your patient. So that's the advantage, and that's why your center is probably very excited to open a proton beam room. But within lung cancer, it's a highly contentious question. What are the data? Patients demand it. We get patients come to us for proton beam. If they came for proton beam, why do they want to go in a clinical trial that compares proton beam to IMRT? To WashU or St. Louis for a reason. Lung cancer is a good source of patients to improve therapy for, because the therapy is toxic. You give chemotherapy and radiation therapy and they have lots of side effects. So if you could reduce that would be great. We have this problem with protons insurance denials. Most private pay insurance companies don't cover. I'll touch on that a little bit. What are secondary diagnoses or group 2 diagnoses that they don't really cover? And then there are always technical challenges. We're trying to bring proton beam radiation therapy into the same image-guided century as we're dealing with in intensity modulated radiation therapy right now. And then I was online, and you all published an article on April 2018. Congratulations, your proton beam went to your treatment room and you measured it, and that's a milestone, and that's great. Back one. Also, 3 weeks ago, the New York Times published what we call a negative article. New York City's putting in the New York Proton Center, and so the New York Times is paying close attention to protons. They published several papers over the past few years about it, and most of them are negative. Positive articles don't sell newspapers, negative articles do. And so this one's about lagging demand, but I wouldn't say it's lagging patient demand. It's really a struggle with insurance companies to prove why proton may be useful for their patients. So let me tell you a little bit about our center. We opened our proton room in December of 2013. We were the first single room proton center in the world. So our company that we bought from is Mevion Medical Systems, and it's a single cyclotron, single room system. But we're a part of a cancer center much like this one, and we have 13 linear accelerators, one proton room. We just purchased a second one, so we're building out our vault for our second room. We have 2 MRI devices, MRI radiation devices. That's called ViewRay makes it. It's called Meridian. We have simulators, an MR simulator, a Gamma Knife, and 2 variant HDR units. Unlike most proton centers, our center is on campus, so it's basically within our department. You can go underneath the street and get to the proton center. So I can see my patients in the same clinic, whether they're protons or x-rays, I see them in the same clinic space. So that's an advantage for us. Also, our attendings can cover back and forth fairly easily with that arrangement. What have we treated? This is the first 3 years. It's more or less the same now. So most of ours have been brain tumors, CNS tumors. That number was 35%. It's dropped to about 30% or so. 20% or so have been lung cancer cases. About 17 to, that's gone up a little bit. To about 20% is pediatric cancers. And then the other quarter is a smattering of all different kinds of cancers. You never know what's going to walk through your door when you open a proton center. You get, I mentioned at a talk last night, you get lots of reirradiation requests, let's say for lung cancer, for prior people who've had prior radiation therapy. So you get all kinds of things that you're asked to treat that they may not feel that comfortable treating in the community, or maybe a patient with a base of skull cancer seeks you out because they have a chondrosarcoma of the base of skull or something. Clinical trial participation is important at our center. About 20% of our patients have been on clinical trial. All of them go on a registry, and I'll explain why there's a need for a registry. I think you all need a registry as well. But we put, let's say we're the top or the second leading accruer for a couple of NRG Oncology trials. We're the leading accruer for a prostate trial called Accrual, which is a comparison of IMRT and compared to protons run through Harvard and Penn. And we have our own internal trials as well. Just a couple of things about what it did for our cancer center. We geographically looked up the zip codes of our patients, and they're coming from twice as far for protons as they did for IMRT, more or less. We have people ask us, well, you know, if you're robbing Peter to pay Paul, you know, if your proton patients are coming from somewhere, maybe they're coming from your IMRT, and maybe your IMRT rates are going down. No, not really. All of our volumes went up when we started our proton center in early 2014. So just measuring our total volume, external beam, it went up. And if you look at volume by quarter, when proton started, things have gone up, and it continues to go up because the patients come in, they ask for proton beam therapy. Maybe you don't think that's right. Maybe you send them to medical oncology and they get treatment there, but you brought them into your system. You ordered x-rays, you ordered pathology, maybe you ordered biopsy, you referred them out. So it's a win for the cancer center. So what about lung cancer? I'm going to talk about the MD Anderson phase 2 trial experience, which is published. They just published this earlier this year. Jing Liao published a randomized phase 2 results for patients with stage 3 lung cancer. That was MD Anderson and Mass General manuscript that was published in JCO. We have an ongoing trial called RTOG 1308. I'm hoping you all will join that when you start treating here. We're going to talk about the differences between those two studies. There are obstacles to proton beam. I'm going to touch on a few of those. And I left out reirradiation, but I mentioned it earlier. There's a growing experience with reirradiation. We've treated about 30-something patients who've had prior radiation therapy, and I'm encouraged by the early results from that, although it can be toxic. If you treat central structures, you reirradiate central structures, you can run into some toxicity. So Joe Chang published this. When was it? It looks like 2017, July 2017, so not quite a year ago. It was a single-arm phase 2 study run at MD Anderson. There were 84 patients. 64 patients were eligible for analysis. They had unresectable stage 3 lung cancer. For non-lung cancer specialists, that's people with mediastinal lymph nodes. good performance status, low weight loss, and they had PET staging. They used passive scattering proton beam. That's not dose painting. I don't know how to explain that, but you guys are getting pencil beam scanning, so really kind of pencil beam painting or dose painting. This was passive scattering technique to 74 gray. Induction chemotherapy was allowed, and they had a fairly good median follow-up for patients with lung cancer. And these were their results. On the left, overall survival and progression-free survival. And on the right, the blue curve is any recurrence, the yellow curve is distant metastasis, and local regional recurrence is the lower curve. So their median survival was 26.5 months, which is encouraging. It's pretty good in stage 3 lung cancer. That's amongst the best that would have been reported, with a 5-year overall survival of 29%. So that's encouraging results for this phase 2 trial. In terms of toxicity, they had pneumonitis or any dyspnea was their highest risk. Esophagitis, if the esophagus is in the pathway of the beam, or you have a patient with a subcarinal lymph node, you're going to get esophagitis, even with proton beam, and then any cardiac event. So you can see the toxicities listed on the right, and they would be as expected. They had no grade 5 events in this trial. So the summary of the MD Anderson phase 2 results I would say they're very good overall survival for this patient population. It was predominantly Medicare age. Deep in the paper, most of these patients were over the age of 65. That's that insurance issue creeping in, and Medicare is more, allows you to treat more patients than private insurance, so most of these proton patients are Medicare patients. And then there's a statement within the method section that they chose patients with larger tumor volumes to go to protons compared to IMRT. That's because of the missing normal tissue issue that you're able to miss, let's say, heart and lung, spare those structures better with protons. And then MD Anderson published this paper in the JCO earlier this year. They ran a Bayesian randomized trial looking at IMRT versus passive scattering proton therapy. And their hypothesis was that protons would reduce radiated lung volume and reduce the incidence of radiation pneumonitis, and at the same time achieve the same local control as the X-ray beam would. Their objectives, they defined protocol failure. It was a dual endpoint, so their endpoints they were following were grade 3 or greater pneumonitis, and they projected IMRT would have a 15% rate and protons would have a 5% rate. And they projected the same local failure rate, 15% at 6 months and 25% at 12 months. So those were their specific endpoints they were looking at. There were some design challenges. They use a Bayesian randomization, which means they could randomize fewer patients, but what happens on a Bayesian randomization is if one arm starts to look better, then more patients go to that arm. So they enrolled more patients on the IMRT arm in this particular trial. Then they randomized only when they pre-planned the patients, and they pre-planned both an IMRT plan and a proton plan. And if it looks like you could achieve the same dose, then they randomized those patients. And that's a challenge because you're taking away an advantage that proton beam might have if you say you randomize a patient and you say the proton beam achieves a normal heart and lung dose constraint, but the IMRT plan doesn't, they wouldn't randomize that patient. They would back down to a lower dose and rerun it to meet the dose constraint. So they took away an advantage of proton beam in their design with this Bayesian design. Eligibility, they included stage 2 through 4. A number of those patients had 3B and 4 disease. So these are some patients had metastatic disease, good performance status, low weight loss, PET staged. Induction chemotherapy was allowed. I reviewed the events, and one of those patients had like 13 cycles of chemotherapy before they got radiation, and of course they got pneumonitis because that might lead to pneumonitis, so that's a flaw in the paper. That happened a few times. This was the randomization schema, and it's a complicated scheme, but it's important to the trial. Let's see if I can point this out. So they, kind of what I was talking about before, they would plan protons and photons to 74 gray. If it was achievable, they would randomize. If it wasn't achievable, they would back down to 66 gray, and if that was achievable, they would randomize. Then they would check with insurance. If the proton beam patient, if the insurance company wouldn't allow protons and it was denied, then they gave x-rays at the highest allowable dose. So what they ended up doing was they had 4 different dose groups in this paper, and it led to an imbalance between arms. You can imagine, you know, if you randomize for protons but you can't get them, that's a flaw in your design. You know, we don't allow that within the cooperative groups. We make you check with their insurance first before we randomize. But that's what they did at Anderson, and they've done it. They also do it with the head and neck trials and other trials that they're running. So this is their consortium diagram, just in a nutshell. They had 105 patients randomized to the IMRT and 76 to passive scattering. And if they were treated, 92 treated with IMRT and 57 treated with passive scattering. So you had an imbalance between arms. And then you had this group that was non-randomizable, 44 patients for various reasons. So you had these 4 different treatment groups, and 26 were denied insurance coverage. And 8 of those patients got the treatment they wanted, which was protons. These are their endpoints: protocol failure, pneumonitis, and local failure, and there was no difference in any of those metrics. So there didn't look like to be an advantage or a disadvantage to proton beam in this group. Some of us would have projected that if you took away the advantage that protons might have and give the same dose, you might expect the same outcomes. They ran into a lower rate of pneumonitis than expected, 6.5% on the IMRT arm and 10% on the proton arm. There was no difference. And local failure, they projected 25% of the year, but they actually only had a 10% local failure rate. So that was encouraging. These are their pneumonitis events, no difference. One thing of note in the patient characteristics table, patients with larger tumor volumes, I've got it in the red box here. Tumor volume makes a difference in radiation therapy because the more clonogens you have to kill, the harder that is. And so they had about 100 cc higher median tumor volume in the proton arm, which would have been a disadvantage. And if they went to 74 gray, which was the target dose they had planned, they were able to achieve that more in the proton arm than in the photon arm. They had published earlier data to show what they spare with proton beam radiation, and this is what they showed with lung and heart. You really, the blue is X-rays and the red is protons. You spare low dose radiation with protons, your target dose isn't that much different. But on the heart side, you spare the heart quite a bit better with protons at all doses. So the theory behind a randomized trial comparing protons to photons is sparing heart dose. This was their overall survival, median survival 28 months, which is really good across the board. There was no difference between protons and IMRT. There was a learning curve to this that they published. The red line is before September 2011, and the yellow line was after September 2011. So they got a lot better with their proton beam planning after the median point of the trial. And if you ask why, the reason is they stopped trying to treat contralateral lymph nodes with proton beam. They reduced their tumor volumes. You know, basically, if you're trying to treat both sides of the mediastinum, then you're going to treat more lung, you're going to get more events. So in perspective, their local failure was lower than expected, 10% versus 25%. The pneumonitis rate was similar to what we've seen in other trials, so sort of as expected. And the overall survival in the photon arm is essentially identical to what we achieved in the randomized trial within NRG Oncology. So that's what would be expected. Why no difference in the primary endpoint? Maybe there's truly no difference between protons and photons. Maybe this Bayesian randomization had introduced study design flaws that failed to, did bias the outcome. Or maybe the study compared a maturing proton, like learning curve with proton, versus something you're used to doing with IMRT. Reviewing the cases, they did use larger margins in this trial than what we've been using at our institution and what we allow in the current trial. So their margins were quite large. And maybe that's the reason they had a little bit higher pneumonitis rate on the proton arm. What did I want to say here? This is their learning curve. So in the later cohort, protons were better than IMRT in over half the patients. In earlier cohort, protons were better than IMRT in only 27%. So there was a learning curve. Maybe it was too early for them to introduce this trial without, for a learning curve. This mentions some of the technical challenges adopted during the trial duration. They got better with planning. They reduced compensator smearing. They reduced contralateral tumor dose coverage, and they increased the number of beams they used. So we had, at the same time, right now we have this ongoing trial. We'll call it RTOG 1308. It's open across the NRG spectrum, and we've got like 10 centers contributing patients to it. And so we didn't want the outcomes of this phase 2 trial to discourage enrollment onto RTOG 1308. So we wrote a letter and sent it to the centers that were enrolling in our trial, and basically the letter said, that the phase 2 trial didn't have a survival endpoint, that the optimal study would have an overall survival as an endpoint, that Bayesian adaptive randomization was difficult, and early radiation pneumonitis events steered randomization towards IMRT. With our trial, we have a 1-to-1 randomization. Randomization was only for patients with both acceptable IMRT and proton plans, which creates bias in the trial. The target dose was the same in each arm, so why would you expect the outcomes to be different in terms of tumor control? 26 patients were denied protons even though they were randomized to it, et cetera. Oh, and eligibility was quite a bit looser in this trial than what our phase 3 trial was. So we've modified recently RTOG 1308, so let me introduce that. The primary objective of the trial is to compare overall survival between proton beam radiation and intensity modulated radiation. These patients get concurrent chemotherapy. This is the design. We're going to 70 gray in both arms, allowing you, but we introduced strict normal tissue dose constraints, so you would back down to meet lung dose and heart dose constraints. Patients, and at least the initial, they got concurrent and consolidation chemotherapy, and you were allowed carboplatin paclitaxel or cis-etoposide. So we had some challenges to accrual. Insurance denial continues to be a big issue for this. We were unable to enroll, we figure we're unable to enroll 30 to 35% of patients we see in clinic for insurance reasons. There are institution-specific solutions to that. Some institutions like Maryland and Penn have taken to negotiate with insurance companies themselves about covering that for their patients. Some, like Mayo, have decided to charge the same amount for protons and IMRT to get around that issue. There's a reduced pool for stage 3 patients because of PET scanning. More patients are diagnosed with stage 4 disease, so there are probably fewer of those now than there were 10 years ago. And there are also many competing trials for stage 3. Immunotherapies come in, and there's competition out there because let's face it, we've had some advances in lung cancer that are quite exciting. This is, the major one. This was published and presented last summer. This is a Pacific trial that shows in patients who got maintenance durvalumab after chemoradiation that doubled their progression-free survival. So we know in our trial we have to adopt, at least maintenance immunotherapy in order to enroll patients. When this trial came out, our accrual dropped pretty low because in the United States you want to give patients these drugs to give them the best opportunity available. So we amended the trial to allow consolidation durvalumab. So we amended it. Overall survival, we introduced co-primary endpoints, overall survival being one, and the second endpoint being development of a major cardiac toxicity or lymphopenia that are related to treatment. The tier 1 hypothesis being that overall survival with protons is superior to photons. The tier 2 hypothesis is that the overall survival may be no different, but that there are fewer cardiac and grade 4 lymphopenia events, and the trial would be considered positive if either arm is satisfied. Why did we do that? Because we had an accrual expectation of over 600 patients, and we were told by CTEP we needed to reduce that in half, so we worked with the CTEP statistician to come up with this statistical design. Sample size is now 300 analyzable patients, so a total of 330. Our current accrual is about 220, so we have, or about 110, so we're about a third of the way through its accrual. We expanded the systemic therapy eligibility, so now we're allowing pemetrexed to be given with a platinum doublet. We're allowing induction therapy that gives you time to fight with the insurance company to enroll the patient, so the patient can have induction therapy. We're also introduced immunotherapy based on Pacific findings. That's up to the discretion of the treating medical oncologist. We're allowing nodal recurrences after surgery as long as that's within the 6 months of surgery, and we've loosened some of the lab criteria. So I mentioned this a few times. This is, insurance denial for protons is a major issue, and it will be for you as well. The University of Florida, Brad Hoppe estimates that from the lung cancer perspective, they can't treat about 40% of the patients they would like to. MD Anderson, on their trial, they had an 8%. Amongst the 10 institutions or so contributing to this trial, we estimate that about 30% of the patients we see can't go on it for insurance reasons. So we've been working with this group called NAPT, National Association for Proton Therapy, and Emory has joined that. I think your Medicare provider is Cahaba. Ours is Wisconsin Physician Services. They're very similar in what they cover with respect to protons. So this is your Medicare coverage policy. It was adopted October of last year. Through NAPT, it expanded. So Group 1 means you don't even have to ask for coverage. It's automatically approved. CNS tumors, intraocular melanomas, pituitary neoplasms, chordomas and chondrosarcomas, head and neck neoplasms, paranasal sinus, peritoneal sarcoma, and pediatrics. Medicare doesn't cover much pediatrics. So that's Group 1. You don't have to even think about getting accrual approval for that. But that's not going to keep 5 proton rooms busy, right? There aren't that many of those patients. So this is Group 2. Group 2 means they're eligible, but they have to be enrolled on a trial or in a registry. So in case Medicare wants to come back to you and query you what you treated and what their outcomes were, you need to have tracked that. So what's covered there? I just cut and pasted it from the policy. Lung cancer, upper abdominal cancers, pelvic tumors that are unresectable, breast tumors, that's in yellow because they just increased the eligibility to include breast cancer, pancreatic and adrenal tumors, skin cancers, lesions in the liver, anal canal, and rectum, prostate cancer, and the other 2 they allowed on were esophagus, B-cell lymphoma, and Hodgkin's lymphoma. So your policy improved based on your participation in NAPT to include those 3 groups of patients. So what are your options for a registry? Forgive me, this is a little bit of a commercial. But you need a registry. You can have your own registry, but they want it, they want it to be a multi-center registry. So you basically have two options: a PCG, which is called the Proton Collaborative Group, that's run out of Chicago with Bill Hartzell, and ours. So we established a registry because we had that issue. We use a software company as a service provider called Radiologica. It's electronic. They store the data. They capture both dosimetry information and medical information. We just signed a contract with Varian for our registry. Varian's your proton manufacturer provider. They're going to build an interface with ARIA for data dump, so hopefully you don't have to pay someone to enter data into the registry, and allow your treatment plans to be downloaded into the registry. And we have 5 members so far. We have a steering committee. It collects typical registry type data elements. We collect the same data elements. We work with PCG to collect the same data elements so that if we ever wanted to combine registries for uncommon tumors, we could combine data. And what it allows you to do is, you do this treatment plan. In this case, this patient with a tumor in the base of skull, well, there's normal tissue doses you want to track for toxicity reasons, and this will allow you to look at any DX or VX metric you want in terms of electronic data capture, and you can pull out any metric you want to look at toxicity. And also we're building in benchmarking. So if you submit a plan, let's say it's a lung cancer plan, we can spit back to you and say, this is how your plan measures up against other plans just like it. Your lung dose is too high, or your lung dose is the median, or your better plan than what we get traditionally. So there's benchmarking built in. So technical challenges with proton beam, of course there are. And anatomical changes during treatment affect proton dosimetry more than they affect IMRT dosimetry, and I'll show you an example of that. Pencil beam use in mobile tumors like lung cancer can be a challenge. They're introducing in-room CT imaging. You will have cone beam CT on your proton machine, and that's good, but that's just been introduced in the past year or so. And we want to get into adaptive therapy, both offline treatment, meaning the patient, we get a CT scan, the patient gets treated, they go home, the next day they come in and get a new plan. We also want to move to online adaptive planning, which means a patient's on the treatment table, you get a scan, you can adapt while the patient's on the table and treat a new plan that day. So that technology is being introduced in other arenas within radiation therapy, and we sure would like to introduce it to protons as well. So this is an example of how in lung cancer, and you can expand this to head and neck cancer, a paranasal sinus tumor, anything. If your target changes in any way or anything affects what's in the beam path, it'll change your dosimetry. So this is a tumor you want to treat with lung cancer with protons, but in this case, the patient developed a pleural effusion. So instead of seeing air, the proton beam is seeing water density. It's pulling the dose back off of your target here, and you're missing. So in proton beam, you have to reassess your patient weekly or every other week with a CT scan to look at your target and everything that's within that beam path to make sure you're treating it correctly. So it's a little bit more cumbersome. Your patient's going to need to know that they're going to get a replanning CT scan, or we call it a verification CT scan, weekly or every other week, and you need a means to do that. What's the difference between passive scattering and pencil beam? Pencil beam is what you're getting, and it is on the upper left, IMPT versus passive scattering. So you get less blue low-dose spillage with IMPT versus passive scattering. It's basically, you've got a small dot, you're painting dose on the tumor. Pencil beam challenges, better conformality for non-mobile cancers. Some centers have stayed away from lung cancer completely because you have a moving target. How are you supposed to have a moving pencil beam and hit a moving target? It's a challenge. Some have gone to breath hold. There's some technical solutions for that. Some have gone to ultra-fast treatment delivery, like speed of the radiation coming out of the machine as a solution. The RPC Phantom, if you participate in randomized trial, like the RTOG trial, you're sent a Phantom to irradiate. For the pencil beam systems, the failure rate's 33% on that Phantom. So it's a high failure rate, and the Phantom's like, gold truth. The solution to that was Monte Carlo dose calculations, which I'm told you guys have research, and so you have Monte Carlo dose calculations, so you shouldn't have a problem with that. We need solutions from mobility, breath hold gating, higher dose rate. In-room imaging is just starting to come into play. Like I said, the manufacturers introduced it this past year. Let's see, yours is cone beam CT. So that's probably good enough for daily localization. It's not good enough for recontouring targets. And so your patients, unless you have a CT scanner in the room, the patient has to probably go get a simulation scan elsewhere in the department. So in summary, for lung cancer, retrospective data and single institution prospective phase 2 data are encouraging for proton beam. The randomized phase 2 trial did not show an advantage for protons. We think there was problems with this trial that have been considered in the design of 1308. We need to show an advantage for proton beam over IMRT, and lung cancer is a major cancer site to do that. There are technical challenges with proton beam, definitely more challenges with IMPT, and when you all get online, we sure would like to include you in our proton therapy group, clinical trial group. Thank you.